Okay, so we're going to have a quick look at an academic assessment of changing patterns with inside health and social care. And we'll look at whether we're moving towards a Big Brother society or really a caring one. And we'll look at some of the issues involved in this. Okay, so as we move into an area of big data, really we need to be careful of how we integrate data. So now the possibility is that we can get health and social care data, police data and education data and really merge them all together in order to be able to better detect the risks that we have to individuals and also of society. So our main aim really is to improve lives and reduce harm. But what we really want to make sure is that each citizen becomes part of this infrastructure that we've created, and we also have some sort of ownership and governance of our data. And the balance is obviously that we've got, on the one hand, we want to be able to detect risks against our individuals and our citizens and our society, but also we might end up with a Big Brother type society where our data is being trawled over. And this is really the move that we have. So our current health and social care systems have typically been designed in an industrial age. They're often centralised, non-integrated, fairly ad hoc, and they're really focused upon the professionals that are involved, with the citizens revolving around them. They're also reactive systems where something happens and then the system will react to it. And we also have limited access for citizens to their own record, health and social care record. And we're moving towards what we could define as a cyber age or an information age. And in this case, the citizen becomes the focus and really the professionals will revolve around that. So we should get not a one-size-fits-all, but a carefully customised health and social care infrastructure. So it becomes distributed, it's much more holistic, it's really focused on the person. It aims to be preemptive, so it can diagnose and find illnesses and problems before they really manifest themselves. And then we get more integration of a circle of trust, such as integrating families and third sector organisations. Okay, so that's our challenge, is how we move from this industrial age into this information age. So what we have really is we might have a child at risk, and the child at risk has data with inside lots of different data sources. So we might see things like posted concerns from a healthcare professional, attendance records within education, healthcare problems, and also some crime trace. And with this, we might see just the signs of a child at risk within inside each of these domains, which is not enough to identify the risk to the child. But when we aggregate together and look across the different records, then we might actually start to see some sort of problem. Just now, we tend to isolate our records, but increasingly we'll be bringing them together to be able to focus around a child at risk. And then we might have a number of stakeholders involved, such as the family, law enforcement, social care, and obviously the child themselves has rights towards how the data is used and has rights towards being part of a child's action plan. So increasingly the family too needs to be involved in this action plan and with the child, and that there doesn't have to be things that are actually hidden away, as the family and the child themselves need to be a proactive part of the action plan. And then inside our formal healthcare systems, we might have an individual who has health and social care needs. And then what we have is that we typically have the data behind what's called a Tier 4 data infrastructure, and this tends to be a highly secure type environment. But what there needs to be is some sort of mechanism to make sure that we also integrate personal health records. So this might be the electronic health record, the formal one, but increasingly what we might find is that the individual themselves may actually have their own personal health data. So how do we make sure that we integrate these records together and also allow access for care workers, GPs, family, and so on? Okay, so it's quite a difficult challenge, and often what we need is this very strong governance system to make sure that we can still provide access to the records from the key stakeholders involved, but also keep the data secure. Increasingly what we see is what's called the risk assessors, and these might be what's called the early warning score system. Early warning score system will look at the medical vital signs and identify if someone is at risk. And also on things like a frailty index. A frailty index will identify when a citizen is becoming frail, such as losing or gaining weight, losing height, and so on. In Scotland, what we have is we have the named person scheme. So the named person scheme will be the person who receives these risks. So the advantage with this is that we can take data from different domains, and then the named person is trusted enough to be able to see any sort of alerts, any risks that are posted, and can make some sort of decision on them. So in this case, there's concerns that are posted, attendance records at school, health problems, crime trace, and so on. And then the named person can then rally around and create an action plan for the child at risk. Then that could be then used to be able to update and monitor the situation. Same thing can happen for health and social care. So the named person in this case would be a GP typically, and they have the rights to be able to look inside the records that are involved. So it might focus on appointments missed, early warning score, frailty index, and so on. So again, the output of this, or the input to the named person, might come from a personal health record. And then it's up to the named person in this case to be able to integrate all the records together to hopefully improve the health and social care standing of the citizen. Again, what we need here is very strong governance of the data, because the last thing we really need is for someone else, say in the public sector, to be able to get access to the information that they really don't have rights to. So what we really need is information sharing to happen between the different stakeholders within health and social care. But unfortunately, there are some barriers, and these are both technical barriers and societal. The technical ones are reducing, but there is still strong societal barriers to information sharing. Unfortunately, just now, the healthcare records are often static. It's very difficult to aggregate data across different records. They tend to be stored in different databases. All the records tend to be in different formats, so it's on different systems, so it's difficult to bring them together. There's also lack of access and lack of trust in the access to the records. And that highlights with poor access control. And along with this, we actually lose a lot of the core data when we aggregate it. So if we take the temperature of a patient over a day, there might be a spike in the temperature, but when we look at it overall as an average, we might just record that and we'll lose some vital data. So increasingly within a big data infrastructure, we actually find that data is stored and not aggregated together. When it comes to societal, there is still a lack of integration between health and social care services. There is a difficulty between primary and secondary healthcare, and there is a barrier between health and social care. There's also 24/7 support is required if we create a proactive healthcare system. Along with that, there is really a lack of information sharing across the public sector in general. But balanced with that, there is actually a strong demand to be able to get access to health and social care data from industry. And then there's a lack of integration between the carers and trusted people and families. So it's difficult to provide access for health and social care, and it's even more difficult to allow families to be part of this circle of trust. Okay, so this is what we have, in that we have the citizen. In this case, we have a child at risk here. So these are the people that might be involved, the stakeholder, in analysing the child at risk. We've obviously got the family, the child. We might have a named person. A concerned individual is the person who might post a concern about the child, and then there is possibly a lead professional who will take forward some sort of care plan. So the challenge that we have is really, how can we bring together education, social care, healthcare and law enforcement to be able to share information, but not for it to be some sort of Big Brother society where someone is spying on the child. And what we really need, and another issue that we have, is how we integrate other healthcare infrastructure such as primary and secondary healthcare, and then create a circle of trust. So it tends to be that we have what's called digital trust. So digital trust is the technical things that are applied to the data when it's stored. It's typically the identity, a strong identity infrastructure, and then a strong rights management infrastructure. Gives us strong control of the data. And then on the other side, we have human trust. And without human trust, then individuals will never correctly trust the data infrastructure. So that we need strong governance. We need to make sure that we know ownership of the data, and then we provide access control, but also that we provide services which are useful to the individuals and which they will subscribe to. So inside our data, a GP might ask, how often does a team meet to discuss the child? Family might ask, who are the people responsible with the action plan? And the social care professional might say, when is the next formal review of the case? So each of the stakeholders will be asking different questions around the data. Okay, so there is some translation of rights of identities and also of rights between the system. So if we want an individual in social care to be access to healthcare, we must translate the rights that they have in one domain into another domain. And then the other problem that we have is how we're going to get citizens to be able to integrate with this system. So few users of healthcare actually have any sort of login into their healthcare infrastructure. And then how do we integrate third sector in integration? And these will come from the integration through formal government interfaces. Okay, so let's look at an example. So the Children and Young People Scotland Act was introduced and it came from the GIRFEC, or Getting It Right for Every Child scheme. And its approach is really to improve the outcomes through public services that support the well-being of children and young people. And it's since become the Children and Young People's Scotland Act. And it focuses on this Sianari approach and is built on giving children a foundation to be safe, healthy, achieving, nurtured, active, respected, responsible and included. And then each of these areas really would define some sort of scoring metric to be able to understand how healthy a child actually was. Okay, so in Scotland, the children are focused on becoming successful learners, confident individuals, effective contributors, and also responsible citizens. Okay, and we have in each of the areas, we have our different objectives from them. But the named person bill has been criticised by some, and some would define it as the spying on children bill. You can see an example here. And there has been some who have said it's the establishment of a universal surveillance system for every child and associated adult in Scotland. And some of the criticism has said that the state seems to fancy itself as being better at parenting than families. And probably one of the problems with the setup of the Act has been that the families don't actually know how the infrastructure is created, how are concerns posed, who deals with them, and so on. So let's look at an integrated model. We'll look at a basic use case of how this could be implemented in real life. Okay, so here is our use case here. There's the child at risk. There's the named person over here, a lead professional. There's the family. And we have here Shirley, who's a concerned individual. Okay, so the child has a named person associated with them. And then in this case, the concerned person posts a concern into the system. And this can either be anonymized or it could be a formal role where the identity of the concerned person is actually logged. Obviously, if it's a certain role and the ID has been checked, then it obviously has more credibility than an anonymous posting. It's what's called veracity in data. Okay, so in this case, the concerned person is filling in some details about the child and the concern. Then what should happen is there's some sort of matching towards who the named person is. So that can be a formal matching, or it could be a lookup system where the name of the child is looked up and the date of birth, say, or some other attribute around the identity could then be matched to the named person, and the named person would then get, say, some text message to say that there's been a concern and they need to log into the portal to be able to see what the concern actually says. So with inside there, the concern will be posted and there'll be some sort of description of the child and then a basic timeline to show what the concerns are and what they've been in the past. And then it's up to the named person to decide who would then be the partners in developing a plan. So if it is a concern and the child is at risk, then the named person might take forward a lead professional. So it could be a healthcare professional or education professional. And then there will be some partners with inside the plan. You can see here the family could be included along with the child and then other parts. So it's really up to them to be able to define the child's plan and then move forward and review that. And then what could happen is that each of the individuals can then work on their own part of the plan and have rights to be able to post certain parts of it. And then what we have is an audit trail. If something goes wrong, then the audit trail will actually define who did what, when, and so on. And we can make sure that there isn't a problem in the future if something doesn't quite go right. So in this case, the GP has rights to one part of the plan, drugs counsellor into another, and so on. The lead professional is the one that's really taking forward the plan and making sure that it's actually implemented, and then possibly closing it with the named person taking on the responsibility after that. Okay, and all along there is some sort of approval of each step of the data. So when data is submitted, then at least the lead professional is there to be able to prove each of the amendments of the child's plan. And then we would have some sort of timeline that would be involved to be able to see what happened when, so we can change and then continually review the child's plan. And there is some sort of export which allows the child and the family and all involved to be able to read the child's plan at any given time. But an important part is there's an audit trail, so that if something does go wrong, then there is some way to be able to trace from it. Okay, so that's the example of the named person in Scotland. Unfortunately, the health and social care within the public sector does not have a strong track record in creating healthcare records which are used, which are citizen focused. One of the best examples of a personalised health record, which is currently in implementation, is the e-Red Book, which is the equivalent of the paper-based version of the Red Book, which provides a record of the child's history, such as their immunisation and height and so on. And we can see that this type of healthcare record is useful because the family actually owns the record, and then it's up to the family to provide the healthcare professionals with logins and rights towards the record, adding new data and so on. Okay, so it differs from the electronic health record. So the electronic health record is typically one that is held by a formal healthcare agency, where the personalised health record is held by the individual or the families involved. There might also be a proxy involved, such as the family might look after an elderly relative's record. So this is what we would see inside the electronic health record. So we have the child here. It will generally show things like weight and height, head circumference and so on, and then any key contacts that we'll have. And a great thing with the health record, the personal health record, is that it will also give monthly, it will also give calendar entries, and things can be changed as required. And we can see here an important part of it is to be able to keep track of immunisations and notes and so on. And in this case, we can actually book appointments online, and then to show the ones that are actually needs to be booked. So a key part of this is now that the family has a more proactive role inside of the child's health. Along with that, we'll see general information, general help information that's required, and this will come from a credible source rather than just being available from the internet. Okay, and then there is information about the child and what's really expected, again to allow the family to have much more of a stake inside their child's health. And we actually have things like immunisation being added, and the whole record can be seen there, and any missed appointments and so on can be highlighted. And as we move towards a big data infrastructure, we have the 4 V's that are typically defined. We have the veracity of our data. That's the trustworthiness. Do we trust to the same level anonymous posting as we do of a concern as we do from a health professional? We have the volume. That's the volume of data that's actually created for our health and social care infrastructure. We have the variety, so that might be to do with images and text and emails and so on. And then we have the velocity. So the velocity is the speed at which the data is arriving. So we might be monitoring healthcare in real time. So that might be quite difficult to actually cope with. Okay, so those are the 4 V's, and along with them you've got the trust and governance infrastructure. So we need to define a very strong governance infrastructure to make sure that data is shared correctly and that individuals have trust in it. Okay, so as part of this assignment, we've got a number of tasks. So have a look at the named person scheme and identify whether its implementation has actually been positive or negative. See if you can find some viewpoints to show that its implementation has been good or bad. Then what to do is look at the strengths and weaknesses of the named person initiative and see if you think it's likely to improve the protection of children, or do the risks against privacy actually outweigh this improvement in the protection of children. And if you find weaknesses within the named person scheme, then identify the weaknesses and see how they can be overcome. A key objective of the GARFEC scheme was to include the families within the process, especially in creating the action plan. So has that really happened? Is there any feedback? Do citizens actually know what's involved, who the named person is and so on, and how the family gets involved? And then in the UK in general, there's a push towards citizen-focused health and social care, where citizens have ownership and control of their own data. Do you think this can really happen in the UK and in Scotland, or is it going to be difficult to implement? So will it be possible with inside our own healthcare systems? Okay, so that's provided an overview really of some of the issues with inside health and social care.